Well, welcome everyone and Happy New Year. Thank you for joining us today's webinar. My name is Cassie Gallucci and I'm an Associate Product Manager at New World Medical. New World Medical is a leader in developing, manufacturing, and marketing cutting-edge medical devices intended to alleviate the suffering of glaucoma patients globally. Today we are presenting our first episode of the ClearPath Conversations webinar series, highlighting the Ahmed ClearPath's data and techniques. This webinar will be presented by world-leading glaucoma surgeons, Dr. Leon Herndon, Professor of Ophthalmology and Chief of Glaucoma Division at Duke Eye Center, and Dr. Davinder Grover, attending surgeon and clinician at Glaucoma Associates of Texas. Just a little housekeeping before we get started. The webinar will be recorded for educational and training purposes. Please mute your devices, and if you have any questions during the presentation, please type them into the question box in your Zoom control panel. The surgeons will bring them up during the presentation, and we will also have time for questions at the end. Now, without further ado, we will turn the time over to Dr. Herndon.
Thank you, Cassie, and Happy New Year to everybody. We're going to get started, but before I do, I just want to welcome Davinder Grover, my good friend. We're looking forward to spending some time with the audience and hope that you'll have a lot of questions about this technology.
Thanks,
so first
Leon.
off, I will share my screen. Cassie already introduced me, and next slide, these are my disclosures. Next slide. So I'm really excited to share with you some data. We all want data with any new technology. And this is data that's been submitted for publication, where we want to compare the post-op surgical outcomes and complication rates patients with the Barbell 350 versus the Ahmed ClearPath 350 implant. Because really there's no data that's been presented in a prospective fashion comparing these two devices. Obviously, we know that the Barbell 350 is, if you will, the gold standard, is the device that's been used in most studies, including the TVT. And the surgeons at Duke were using the Barbell and the ClearPath interchangeably at the point. Subjects were eligible for the study, had a baseline visit in which several variables were measured. And the patient underwent standard superior temporal or inferior nasal placement of either Barbell 350 or ClearPath 350 implant. Importantly, these procedures were performed as a standalone procedure, not combined with cataract surgery. Next slide. Briefly, the inclusion criteria, as you see, the valveless aqueous shunt was the planned surgical procedure. Patients with primary glaucoma, pseudoexfoliation, or pigmentary dispersion, or traumatic glaucoma with previously failed trabeculectomy or other intraocular surgeries were included. And as I mentioned, standalone surgery. The standard exclusion criteria are as noted there. Next slide. So in our baseline demographics, there were 37 eyes that were randomized to the Barbell arm and 39 eyes or patients who were randomized to the ClearPath 350. You see the racial demographics there, no differences between the two groups. Diagnosis, more POAG patients in the ClearPath group than the Barbell group. Severity, these were mostly severe stage glaucoma patients. And most of these patients had previous incisional surgery. Next slide. So to get into the meat of the results with the limited time we have tonight, we follow patients out to 12 months in a prospective fashion. And I'll just draw your attention to the red boxes, week 6, month 3, and month 12. At week 6, the mean IOP was 16.28 in the Barbell arm versus 12.11 in the ClearPath. Month 3, statistically significantly in favor of the ClearPath group at 12.77 millimeters of mercury. And then fast forward to 1 year. So 1 year, our data showed an IOP of 14 millimeters of mercury in the Barbell arm compared to 11 millimeters of mercury in the ClearPath arm. And as you see, there is also a significant reduction in IOP change. 24% at week 6 for the barbell versus 43%. And we fast forward to a year, 30% IOP reduction among the barbell patients compared to 44% IOP reduction among the ClearPath eye, statistically significantly lower or greater percent reduction. Next slide. So our findings show that the Ahmed ClearPath 350 seems to provide better long-term IOP control compared to the barbell 350 implant. There was a similar safety profile between the two implants. And there are no statistically significant differences between the two interventions in terms of surgical time, post-op glaucoma medications at any visit, or post-op complications at any visit. Next slide. So one thing before we get to Davinder, and I'll ask you also, Davinder, what features of the ClearPath appeal to you most for your glaucoma patients?
Yeah, well, Leon, first, congrats on this study. It's really so important to show these comparative prospective studies. It's a huge effort and is no small task, and that needs to be clearly recognized. So congratulations for pioneering that. It's really, really exciting to see that. I do exclusively 250 ClearPaths now, and the reason why I like that is I do all my cases under topical anesthesia, so I'm not blocking my patients because it doesn't require muscle isolation, and I think the low profile of it is safer, and we're seeing, as I'll talk a little bit about, I think a lower rate of erosion, although it's pretty rare, but more importantly, a lower rate of double vision, which for me is, when I'm thinking about a drainage implant in a patient, that's the one that hurts the most. So when you give a patient double vision, it's just miserable. And so that's what I really have seen significantly, I think, with the lower profile, the smaller plate size, and the favorable outcomes have really allowed me to have confidence with it.
Yeah, one thing also that we looked at in our study, we didn't have time to discuss tonight. We did several questionnaires, quality of life questionnaires. We also did motility evaluations at baseline, 6 months, and also at 1 year, and compared the two groups. We're just crunching the data now on the motility, but the diplopia rate and motility exam, the diplopia rates seemed to be less with the ClearPath 350, as you surmised with your patients with the 250. And the questionnaires were more favorable in our ClearPath arm than the barbell.
Huh. These are like patient comfort, patient reported outcomes.
That's right. That's right. We had several different scenarios and battery of questions that we had patients answer before the study and reflected back after the study to see if there were any differences.
Wow, that's fascinating.
So tell us about your experience, Davinder, with the 250.
Yeah, so I've switched to a smaller plate size for a long time, because I think there's a good amount of studies out there showing that there's comparable outcomes with 250 and 350, or even size with the Maltino 245. And so I've moved over. I was doing a lot of Barbell 250s, but even with the Barbell 250, I was still putting it under the superior rectus. And now I've switched entirely to 250. And can we do the next slide, please, and show you some of the outcomes we have. These are my disclosures. I am a consultant for New World. But this is, looking back at our patient group, you can see the breakdown. Our patient population was more heavily Caucasian, as opposed to the study that Leon just presented. Most of our patients had POAG, and a lot of them had prior procedures. So these were, the type of patients you would see that were best candidates for tube shunts. Next slide, please. And this is a retrospective study, but we actually have some pretty good long-term data and relatively decent follow-up for this kind of study. But we only used one eye of each patient. So if they're bilateral patients, we randomly selected one eye. But if you look at baseline, and this is a 250, so it's not a 350. These are all 250 ClearPaths. At baseline, patients had pressure of 25 on over 4 meds. And you look at the 12-month time period, and you see quite similar numbers to what Leon was presenting with his 350, which is pressures of 13, and our patients went from 4 down to 1.8 meds. And the group that we followed with over 24-month follow-up, 47 of them continue to show significant pressure reduction, as well as a significant decrease in the dependence on their drops. Next slide, please. So no surgery in glaucoma is without side effects, but the side effect profile was not much different than what we'd expect with any tube shunt procedure, and they were all relatively rare and not nothing that we could not take care of. More importantly, what's missing on here is notably in these is a smaller number, 67 eyes, but we did not see any tube erosions over the follow-up period, and we did not see any double vision, which for me is a big deal. Next slide, please. And so that's kind of my outcomes, and we can kind of bridge now into I guess the surgical technique session, unless you have questions, Leon.
Yeah. I think it's interesting that conversation about 350 versus 250, isn't it?
Yeah.
There are not a lot of good studies that compare 350 to 250. There's a retrospective out of Wills that looked at 250 barbell, 250, 350 barbell, as well as 250 and 350 ClearPaths.
Yeah.
And showed really no differences to speak of. So you may be right. Certainly the 250 takes less time. I don't know if you'll go through the technique of using a taco style to get through a smaller conjunctival incision. But that needs to be considered. Certainly we saw an IOP of 11 millimeters mercury at a year.
Yeah.
You've seen about 13. So maybe size does matter. But I do think we need to look at a procedure that can be done in less time and that can give great results as you've shared.
Yeah, and I love the fact that this can be done under topical anesthesia. That I do a subtenon's. I give a subtenon's block after I open up the conjunctiva. But I think not having to manipulate the muscles is probably a better thing for the patient and lowers the risk of double vision. And the other thing that I do, what really moved me from the larger implants to the smaller implants is the other big data set out there showing the efficacy of low energy CPC diode after tubes, right? When you compare second tubes to low energy CPC diode. And so my philosophy is, look, I'll do a 250. I think it's a smaller, safer, more efficient implant. And if I don't get down to where I need to be, I have no hesitation performing low energy CPC diode. I think the efficacy and safety is convincing, and so even if I didn't get where I wanted to be with the smaller implant, I can get there with a very safe procedure that doesn't involve an incision on the eye.
How about a second tube, Davinder? Let's say you've done a 250 ClearPath and have done low energy CPC. You're still not getting what you need. Where do you go with that second tube?
Yeah, so I I think we both have very busy practices and very busy surgical practices. And I switched doing this to the low energy CPC diode probably about 8 years ago. And before I did that, I would say I was probably putting an inferior nasal tube in an eye 2 or 3 times a week. Okay. And now I'm probably doing an intranasal tube once a year. So it's extremely rare that that I have to actually lean on doing a second tube. I'll do low energy CPC diode, 4,000 milliseconds, 30 spots. depending on the age and of the patient, the number of meds they're on and their pressure, I might do 700 milliwatts, I might do 900 milliwatts, I may do 1100 milliwatts, but pretty low. I'm pretty conservative about it because, like I tell my patients, I can always turn down the faucet, I just can't turn it back on. So I tell them we're going to take baby steps. I'm going to start off safer, more conservative, and see how they respond with 800 milliwatts or so, and see where we get to go. And the other thing that I think is so key, and I'm sure Leon, in your career you're seeing this as well, is this tube-associated hypotony, right? Where you have these patients where you put a 350 bar velt in them at 65, and now they're coming to you at 80, and their aqueous production is going down, and now all of a sudden they're on no meds and their pressure is 9, and then they come in and their pressure is 6 and they're on no meds, and so I kind of like my patients to be on one drop. So I have the ability to turn up or down the faucet in case they start getting lower pressures with age. Are you seeing that at all?
Yeah, absolutely. It's very frustrating when you have hypotony after a tube. There are lots of techniques that we have time to talk about how we manage that. But one question that may lead right into the conversation is the question. Lawrence has a question about, when do you start withdrawing topical medications after your surgery?
Yeah. So that's actually, I guess we can go. Do you have whose slides are next on the technique? Is it yours or mine?
I think they're mine.
Okay. Because I'll answer that when I get to my
Okay,
my section. But why don't you
good enough.
lead the way, sir?
Good enough. So this is a narrated slide video. You can start playing it, Cassie. Okay, I guess I will narrate it. So this is a ClearPath 350, as you see, and you can use the ripcord that comes already prepackaged. I tend to take it out and use a 6.0 Proline. This was a combined procedure, phaco barbell on my ClearPath 350 in the superior temporal quadrant, back when we had resure sealant. And corneal traction suture, I started about 4 or 5 millimeters back. This is the superior temporal quadrant of the left eye. Westcott scissors to create the space. And you see how easily the ClearPath, even the 350, goes behind the muscles, because I really like the flexibility of the ClearPath. I measure 7 to 9 millimeters posterior to limbus with 9.0 nylon suture. And then I use a 22 gauge needle to create my sclerostomy. And in this case, I'm threading the tube into the sulcus. And this is my technique of using a vented slits and wicks, and we'll go through this in more detail, I think, on my next video. Tubulectomy sclera is my patch graft of choice. And then I close the conjunctiva with the running 8.0 Viper suture. So to get back to the specifics of this approach, I like the superior temporal quadrant for my first tube. With the 350, you obviously have to isolate both muscles, the rectus lateral and superior rectus muscles. One thing is, I teach this technique to fellows and residents. They are used to the more rigid plate with the barbell. So there's a little learning curve to having the more flexible foot plates or flexible arms to place behind the muscle. But I found that it really is an advantage of getting the muscles, getting the plate easily behind the muscles. One advantage of the anterior foot plates is that it's easily accessible. My technique you saw in this video real quickly, where I use 2 interrupted 9.0 nylon sutures. Now I'll just use 1 horizontal 9.0 nylon suture through both eyelids. The knot's already buried, and that's a little quicker approach to securing the plate to the foot plates to the sclera. If we have time, we can talk about sulcus placement versus placing a tube in front of the iris. I favor sulcus in the pseudophakic eye. It's always I'm a firm believer that the further you can get the tube away from the cornea, it's got to be better in the long term. And I think let's show the next video. I'll show my the way we manage early pressure control. Obviously, those of you on the call who haven't done a lot of non-valve tubes, you have to tie the tube off and with a vicral ligature, because you need 4 to 6 weeks for the capsule to form to give you some resistance to flow. So what are you going to do for those first 4, 5, 6 weeks with the vicral ligature in place? Lots of different techniques. This is one that we published a few years ago, where we use a nylon wick technique for early pressure control. This is a retrospective study of patients who, in the previous study, we did just fenestrations. There were 37 patients in that study. And then in the current study, we did fenestration, the 2 fenestrations, and also 2 nylon wicks, as I'll show. We had 92 patients, barbell 350 or ClearPath 350. We did a baseline pre-op data and follow patients post-op week, day 1, week 3, week 5, and month 2. Next slide. So what I'll share with you is that in the top left part of the table, those eyes, those 37 patients who had just fenestrations versus the technique when I'm sharing with you the fenestration in the wicks out to 2 months. So post-op day 1, IOP, if you continue down the left-hand column, 14.4, and those who had the fenestrations was 12 millimeters of mercury with the fenestration in the wicks. Post-op week 3, we do see the spread, and this is when you're going to get into some trouble in some cases if you have the ligature and may see some pressure elevation. Those eyes that had just the fenestrations had an 18 millimeters of mercury. Those that had fenestration in wicks, 14 millimeters of mercury. And going down to the far right, if you go out to 2 months, we see that the millimeters of mercury were significant, not significantly different, 13.8 in those that had fenestrations versus 14.6 those with fenestration in the wicks. But the key time, again, is that first 4 to 6 week period of time when you're waiting for that vicral to release. Number of medications was significantly lower in those eyes that had the fenestrations and wicks, as you see. One thing I'll share, Davinder, back in the day, when I have a patient with really severe glaucoma, loss of conjunctival scarring, and if I would, in that case, we're just doing a barbell 350. The problem is as I mentioned, you don't get control until 4 to 6 weeks. So one thing I used to do a lot of was double tubes. Mm-hmm. We were doing Ahmed FP7 in one quadrant and a barbell 350 in the other quadrant. But since I started this technique, I haven't had to do a double tube surgery. And the cornea appreciates that. Let me show you the video of this technique. Next slide. So the tube is placed. I use a super blade, 15-degree blade. I make 2 venting slits, enter the vicral ligature, and then we'll take a 9-0 nylon suture in front of the first venting slit, and then behind the second venting slit. I tell my fellows and residents, make sure you're right in the middle of the tube because you don't want to lacerate it. And then we're able to cut those about 4 to 5 millimeters in length. Next slide. I think if you look closely in this next slide, you may see some percolation along these, along one of the wicks. It may not demonstrate very well, but there's nice aqueous percolation through one of those nylon wicks. So this is a technique that works. I'm sure Davinder has a technique he can talk about what he does for early pressure control. But I've been real pleased. We looked at this with 7-0 vicral as wicks, but did not see a good early pressure control with that. But 9-0 nylon is what my technique has been for the past 4 or 5 years. Let's see, we have some questions in the chat. Maybe we'll address that before we get to your video.
Yeah, one's about pediatric use. But then the, I guess one that's pertinent to your talk was the what needle to use for the 9-0 nylon. Do you know what?
The one that the surgery tech gives me. I'm sorry. I don't know.
It's probably a spatulated needle.
Yeah, it's a spatulated needle. I don't know the model number of the needle.
And then
I,
I guess we
I
can
want to
have.
answer the question about the pediatric. Fortunately, I don't do pediatric glaucoma. We have Sharon Friedman, world renowned Sharon Friedman, who does all the pediatric patients. But I may get a younger patient, early, mid late teens, and so I have done ClearPaths in those patients,
Yeah,
and
I
had
mean,
not faced any roadblocks with insurance.
yeah, and I agree. I mean, we do a ton of kids here. All of us, most of us do, and you know, after going down the path of if we're stuck to doing a tube, if we've exploited other options, I have no hesitation to and receive no roadblocks for doing any kind of tube in a kid. But yeah, my go-to tube also would be a 250 ClearPath in a baby.
All right, Cass, let's go to the vendor's videos.
Okay, so and it's probably because I might be a control freak, but this is how I tie off my tubes. We talked about why I like the 250 ClearPath, but I'll tell you what these sutures are. Can you go to the next slide, please? So we talk about there's all these different varying, and these are all the techniques I came up with. And Leon, please add to those if you think of there's other ways. But when tubes were first being done, I know when one of my closest mentors and partner Ron Fellman, when he started doing tubes, especially in kids, they were doing the tuck the tube on the side and then go back in 2 months later and plug it in. But the traditional way is with the Vicryl, or with a Vicryl and a ripcord, and then you can have more permanent ways of doing it, like with a Proline or a Nylon. Those require either a return to the operating room or lysing it with a suture with a laser. Done techniques where you've done a proline occlusion in the AC, and then you can just do low energy argon to melt that proline. But this last one is really is my standard procedure now. Is I do not use the ripcord that comes with the ClearPath. I use a 7.0 proline. And I use a 4.0 nylon as the 4.0 nylon is the ripcord, and a 7.0 proline is I tie it off. And then I leave the ripcord in and I tuck it in the subconj space inferiorly. And we can go next slide, please. And I did that because I hated seeing patients come in at 5 weeks or 6 weeks and their pressure was 30 and on max meds because their tube hadn't opened. Or I hated seeing patients come in at 5 weeks and they're still on Diamox, still on max meds, and their tube opened at 4 weeks and they have a flat chamber. And I'm reforming the eye in the anterior chamber in the clinic. And that unpredictability kept me up at night so much. I hated it when I would tell my patients, especially your young functional patients, okay, no bending or heavy lifting for the first 10 days after surgery, and then you can go back to everything normal. But at 4 weeks, from 4 to 6 weeks, you got to stop doing any activity. And a week after the tube opens, you got to stop doing any activity. So, I mean, they were out of work for a significant period of time. Now with this technique, I basically say no heavy lifting, no bending over for 7 to 10 days, and then go back to everything normal. And we'll start back on drops, and I'll just watch you. And then when your pressure goes up, I'm going to slowly restart drops. And when your pressure goes up to the point where I can't control it with drops, then we'll activate the tube and we'll plan it. So take a week off work, come see me the day before, come see me that day. You're off a week of work, and then go back to work the next week. And it's under control. It's under my control. It's under their control. When I'm not seeing these flat chambers, and it really, I think, is it's provided a lot more peace of mind for me. And I'm not reforming chambers. I'm not seeing flat chambers. And what's crazy is can you go to the next slide, please? I call this technique a tubulectomy. I thought Leon would like that term. So essentially, I'm creating my own micro shunt. Okay, and I'm fenestrating pretty aggressively. I'm using a TG130, sometimes the TG140 needle. That's the TG140 is the needle that comes on the ninoproline. And I'm fenestrating a lot to the point where it sometimes makes people cringe. But I'll do 5 to 10 fenestrations, and I really want some good flow. And but when you do that, you need to close the conj like you're closing a trab. Because if you just close it really quickly with some atovicryl, that the fenestrations are going to flow, and you're going to get not always, but you can get a leak, and so you need to be much more meticulous on how you close your conjunctiva. So I close it with a nylon, and that has to then be removed, which is kind of a pain in clinic, a couple months later. But by doing this, my patients don't get their tubes activated at 4 weeks or 6 weeks. They actually get their tubes activated sometimes at 3 months, 6 months. I've had patients where my fenestrations have worked for a year. Leon's been a glaucoma specialist for a very long time, so he knows the whole idea of this evil aqueous. And when you were shunting evil aqueous to the plate, you get a pretty aggressive inflammatory reaction. And I tell you, there's nothing more peaceful than activating a tube at 6 months or 9 months when the eye is just perfectly quiet. I think the blebs are the flow to the plate is different. The capsule is different. There's the inflammatory response is much less. The hypertensive phase is lower. And so it's really just changed my whole practice pattern. And I've been doing this for about 7 years now. I'm not using Helon every week now in the clinic to reform these chambers. Can you go next slide? And actually, okay. And so this is something that I developed with a good friend of mine, Patrick Goy, from Canada. With the Barvelt would come in a clear case, and it would be sutured down. And so I'm all about trying to be the most efficient as we can in the operating room. And so I usually will tie off the tube on the back table while my patient's being prepped, and while my OR team is getting the patient ready. And so while they're doing all that, I'm prepping this in the back table. And with the Barvelt, it was great because it was sutured to this plate. And so the plate was stabilized, the tube was stabilized, and I can tie it off and do everything. That was not that you don't see that with the ClearPath, and you don't see that with the Maltino. And so my Patrick Goy and I kind of put our brains together and developed this technique to stabilize the clip, and then you can kind of see those little kind of grooves, 5 grooves that are basically allow you to fenestrate predictably and reliably with a 30 gauge needle. So can we go to the next? I think the next slide is going to be the video of this. Yeah, so we can show this video. So this is just me on the back table showing we call it the GG disc drainage implant stabilization clip. Ron Feldman came up with that name. So this is a 9.0, sorry, it's a 7.0 proline. And now you can see that I'm making sure it's watertight. And then with the 7.0 proline, you want to keep them long. You want almost like you're suturing a lens. You want it to lay flat against the eye. And then I'm going to perform my 5 fenestrations. Going through, you test your fenestrations, and this whole time my staff is prepping the patient. And you want to test your fenestrations, and then you can leave it off. And I have the needle on to that 4.0 nylon as a thing. So that's been a nice addition of efficiency in my clinic. My OR by being able to prepare the plate on the back table while the patient is being prepped and draped. I know we can go to
that's great.
So this is this video. I did not edit it down as beautifully as Leon had his. So Cassie, I might have you jump ahead a little bit, but it's a ClearPath 250, and I'm using another instrument that I kind of designed. That's kind of my go-to. It's called the go-to forceps, but it's basically conjunctival forceps. It'll help me manipulate the implant. So that's the implant that is ligated with a 7.0 proline and a 4.0 nylon ripcord. And then, my second instrument helps me stabilize the the tube. As I'm tying it down, I make an incision at the limbus. And then I can, I don't know if can you guys see that? It's kind of choppy for me. Are you guys, is it coming
Looks
through?
good.
Okay. And then I'll use it to trim my tube. It basically does everything for me. It cuts, it holds everything. I can manipulate the tube. I stabilize it as I'm fenestrating it even more. So I'm securing the tube to the plate, to the sclera with a ninoproline. And I'll rotate the suture. I leave it long, and then I'm going to just fenestrate. And I'm going to fenestrate. And this is partial thickness cornea. I think it's less noticeable when the patients have exposure. And then that second instrument never leaves my hand. And I'm using it to cut the suture, to manipulate everything. And so I'm not passing stuff back and forth to my scrub tech. They actually get bored now while I'm doing the case. So this is me tucking that ripcord down below, and I tuck it way down below. And then I can just trim it. And then in this video, I'm closing the conjunctiva with atovicryl. But like I said before, I'm now a little bit more careful with how I close the conjunctiva, because you can get some leaks if you fenestrate more. What I like about this instrument is that it doesn't shred the atovicryl, and it doesn't break the nylon, and I'm not constantly passing back sutures and all that stuff, or scissors, and then I close it. So we can, I mean, that's kind of my closure. This is I make a incision at the limbus and close it at the limbus. But that's kind of my technique. I think that's just me closing the cons. We don't need to see that. We can move that forward.
Yeah, I love your aggressive fenestrations, huh?
Yeah, it makes people cringe, and it's counter to a lot of the way I was trained, and I would say ease into it, number one, but the most important thing is you've got to be meticulous and close it the way you would close a trabeculectomy, because I mean, it's basically my own micro shunt, and I'm getting these fenestrations to work, 3 months, 6 months. So I'll do this in patients that even, previously I would do an FP7. I'll do this in my patients. So I rarely do an FP7 now, because I can get their pressures down with aggressive fenestration. So even my neovascular glaucoma patients that have pressures of 40, I can get them through 2 to 3 months with my fenestrations. And I don't like to activate the tube at 6 weeks. The earliest I would like to activate my tube is 2 months. I really cringe at opening up sooner, because I think the eye is still pretty hot and pro-inflammatory.
That's great, Davinder. So you've seen different techniques, different models. Davinder favors the 250. I favor the 350. Different ways of tying the tube off, creating fenestrations, different devices to get around the early pressure control. So in the time that we have left, we're going to open up for questions. Cassie,
I think we got a couple questions on the chat box. Leon, do
okay.
you want some? We got someone from Chile talking about the use of mitomycin C. There's some movement towards using mitomycin C with FP7s. I would strongly discourage you from using mitomycin C with non-valved implants. I think that's pretty dangerous. We won't form an appropriate capsule. What do you think, Leon?
Yeah, back in the day with FP7s, mitomycin was being utilized. I have not used it with any of my devices, so I don't have much experience with that.
Yeah. And then we have a question by Caroline about doing a 311 on the 7-0 proline around the tube. Yeah, I do that. I actually do leave the tube. You could leave it on the posterior surface. I think that would probably be safer. What I tend to do is I leave it anteriorly, but then I leave it long, about 2 to 3 millimeters, so that it lays flat against the sclera, and you don't have any sharp edges pointing up, putting you at risk of it eroding.
Another question?
Yeah, is there a ripcord that can be utilized to eliminate the need for ligation? I don't think so. I guess you could probably try to occlude the tube with a 3.0 or suture, but I I don't know. What do you think about that, Leon?
Yeah, no, not, I wouldn't recommend that. There are some devices, the Paul implant for one, has a smaller lumen.
Yeah.
It's been talked about not having to ligate that, but I don't have experience with that. So for what we use, I clearly don't see a ripcord large enough that you could adequately block the lumen.
Yeah. We got a question about explaining your fenestration method in my practice. The 1 to 2 that we place usually close within a couple of weeks, and are yours lasting longer? Yeah. So I think, I think both techniques we showed are a great way to ensure the fenestrations last longer. Using the wick technique that Leon shows is, I think, a very predictable way. My way, I'm doing the TG 130 needle, TG 140 needle. That's the needle on the 90 proline. And I'll just walk it back. And again, what Leon was saying is you want to make sure you're going through the center of the tube. You don't want to lice through the side of it and have it gaping open. And I'll just kind of make gradual ones all the way back, and get some good flow. There's a question about hypotony. I gauge the number of fenestrations I do based on the patient's pre-op pressure and their pre-op meds. So if the patient's pre-op pressure is 19 or 20 on max meds, I won't fenestrate as much. I might do 4 or 5. If the patient's pre-op pressure is 40 on max meds, then I'm doing 10. But again, just be very careful. I would say don't jump off and do a case tomorrow and do 10 or 15 fenestrations. I would say, do 5 and
But
be
the vendor said I could.
yeah, exactly. And be careful how you close it. And you can see the eye. You can pump up the eye with BSS and see how they're flowing. And that'll give you a sense of if you need to do more fenestrations or not. We're getting a
That's a
lot.
question for me as far as my ligation technique.
Yeah.
So I use a seminal vicral ligature. I like to tie right at the eyelid holes on the anterior foot plates. That's where I tie my seminal vicral ligature. I use a ripcord 6.0 Perlene ripcord on every case. And so I'm kind of opposite from Davinder. It's amazing with glaucoma you can do things so differently. We published a prospective study where we looked at how early can you remove a ripcord. And in a prospective fashion, we found that we can safely remove that 3 weeks.
Yeah.
Now, these are patients that have really high pressures at 3 weeks, significant optic nerve damage. If I do pull it at 3 weeks, then I will place some viscoelastic into the anterior chamber. And so the earliest that the capsule I think is forming is at 3 weeks. But I was not using ripcords until I guess the past 10 years. Before that, I'll be concerned about what I'm going to do about pressures at 4 or 5 weeks where the pressure is too high. So the ripcord gives me a little safety valve, a little confidence that I can help the patient out during the early period.
Got a question about pulling the ripcord and activating it. So Leon, you tie yours off with a vicryl. So you leave the ripcord in place.
That's right.
And, if 3 months later the pressure's creeping up, have you found benefit in removing that ripcord?
No, I haven't. The vendor, really after 6 weeks, yeah, I've had referring doctors say, "Oh, I'll send you back to Herndon to pull the ripcord to 2 years." Really, after 6 weeks, I don't get much.
Yeah, I agree.
And the questions asked, have I completely switched to using the ClearPath 350? I have for superior tubes. If I had to do an inferior tube, in our study, we did not significant difference, but we did find some erosion rate for inferior tubes. So I not significantly higher than the barbell, but if I'm doing an inferior tube, a big tube, I'll use a barbell 350 still. But other than that, I'm doing the 350 ClearPath superior temporally.
Yeah. In the rare situation I do an inferior nasal tube now, I will throw down a 250 ClearPath. with that too as well. And we haven't seen major issues with that technique. What I do when I pull my ripcord is, so it's a 7/0 proline that's around the tube, and the ripcord is in the tube, and that's a 4/0 nylon that's tucked inferiorly. So just when I decide to open it in clinic, I'll put a lid speculum in the eye. You just numb up the eye with tetracaine, and then with 2 ties, I'll basically find the ripcord in the inferior fornix and just pull the conjunctiva apart, find the tube, and pull it out and activate the tube. So the tube will not activate based on the technique that I use. The tube will not activate until I pull the ripcord. So that's different. It's important to note that that's different than the technique that I think a lot of people use, and the technique that Dr. Herndon described, which is tying off the tube with the Vicryl that will activate whether you're ready or not in 4 to 6 weeks.
Let's see if there's any other questions here.
Yeah, I think we got them. When do you start withdrawing topical meds? So yeah, so I mean, I fenestrate the heck out of it. So my pressures are usually pretty well controlled, but sometimes fenestrations are so unpredictable. And sometimes the pressures are not where you want them to be. Sometimes you get inflammatory material that kind of clog things up, and then the fenestrations start working a week later. So I will just, I'll treat the IOP as I see fit. If the pressure's low, you use atropine to kind of keep you safe. But I will titrate the meds based on my goals.
Yeah, I would say at post-op day 1, I make a determination many times with the technique, the wick technique that I share with you. Patient's pressures are already in low teens, and I'll just manage them. But I do prepare the patient for the fact that your pressure is likely going to elevate in the next 4 to 6 weeks. So oftentimes we'll place them on one topical medication and follow them.
And also, I mean, we're talking on meds, when the tube does activate, I mean, I think it's so powerful for both the valved and non-valved implants to as the pressure starts to slowly creep up, to put them on a beta blocker to really help mitigate that hypertensive phase. I think that's so important to do after you activate the tube. 10 days later, 2 weeks later, you'll see a slow rise in pressure, and it's important to kind of jump on that with an aqueous suppressant. What are your thoughts on that, Leon?
Yeah, I definitely agree with that approach, Davinder. Cassie, you have any other questions for us?
There's one about 250, 350 ClearPaths. I think we kind of have state that. Leon's a 350 guy. I'm a smaller guy, so I'm a 250 guy.
Yeah, I will tell you, I like the 250 in the scenarios that I would use it. Based on the severity of glaucoma, if I have a patient who I think can do okay with low to mid-teens, I'll do a 250. I do like the 250 in severe uveitic glaucoma, and there's a question about, do you do EP7? If you've got severe disease, I think I need a little bit lower than what EP7 will give me. So I do like a ClearPath 250 in that case. I wouldn't go with the big 350 in those cases. But the nice thing also that another technique of placing the 250, Paul Singh first found out about this technique from Paul, that you can use a much smaller conjunctival incision, even 5 millimeters.
Yeah.
To fold that 250 in a taco style and place it into the superior temporal quadrant. So I still do use, I would say, of the ClearPath, 15% of the time, I'll do a 250.
These are great questions. Thank you, guys. This is how it keeps it interesting.
Yeah.
Well, if there are no more questions, that's going to conclude our webinar. Thank you again, Dr. Herndon and Dr. Grover, for joining us this evening. For more information on ClearPath and the rest of our product portfolio, please visit newworldmedical.com and the Learn platform for training and practice resources. I hope everyone has a great evening tonight. Thank you.
Good night.
Thanks. Nice job.